probably never leave me. And it was not necessarily in my treatment, but in the treatment of somebody else that I observed. This is this person who's unable to speak, and she's, you know, having that treatment. They have lasers, they have music going, and I think the whole office came in and started singing this song together to encourage her to be able to speak. And you just don't find that everywhere. That compassion for someone, and that the uniqueness to come and want to be a part of it and sing with joy and love, like that will probably never leave my mind. Like I honestly, I got goosebumps when I was watching it, and I thought, oh, God is most definitely present here.
So as a caregiver, you hold so much of their trauma in yourself. For me personally, I was trying to take his trauma, trying to take his pain, trying to take all of that into my own body so that he didn't have to feel that. And I thought that I had let it go, but until I sat with Dr. Jerry, like, I had not let go of it, obviously, because I still felt that tension in my body. But as soon as she did that to me, it was like a full release of just everything. And I let out a huge breath, and Jaden let out a huge breath at the exact same time that I did. We're so connected that if I let my trauma go from this situation, he'll feel that trauma leave his body too. And then he can feel the peace, then I think he has the opportunity to heal.
We have some new technology. This is SoftWave. I'm extremely excited about this for multiple reasons. We're one of the first clinics in the world to be using it for brain applications. I've had some first-hand experience on some amazing regenerative capacity with this machine on what it can do for the brain, restoring function extremely quickly, getting people out of pain faster than I've ever seen before. I've literally seen, even this week, I've seen primitive reflexes literally inhibit or integrate faster than I've ever seen before when we use it on the brain, but then also specifically for those primitive reflexes. We're the first to do it, that kind of application, which is really exciting. We'll continue to do some pilot studies. We're working in collaboration with SoftWave to do those research studies. So extremely excited. We're also using this now in combination with our B-cell procedure, using it before and after to help enhance the stem cells, which it is clinically proven, but also proven in the research to enhance, upregulate that stem cell response. So very excited about that.
All right, welcome. Introduction to SPML. My name is Dr. Yngve. I'm from the Houston-Galveston area. And so this is the main session I'm going through. We're going to talk about minimally invasive surgical procedures at the ankle, knee, and the hip and understand their indications. And probably, if you would see me later, we could go over the rehabilitation principles, orthotic treatment, and the research. So this is a favorite thing for me to talk about because I started doing this because of a physical therapist. There was a physical therapist I used to always work with. She went to a conference, and at the conference there was another physical therapist talking about this percutaneous surgery, which is, I'm calling SPML. And the physical therapist actually had a child with cerebral palsy and said, my child had a conventional surgery, then had this minimally invasive surgery. It worked just as well and had very good results. And so my friend, the therapist, said, well, that's very interesting. I'm going to go talk to the child who had come to the conference with her mother. And she talked to the child, and the child said, yes, absolutely. So then next time I saw that therapist, she said, have you ever heard of this? And I said, no. She said, well, you need to start doing it. And so that was about 15 years ago, and eventually I did. And it basically changed my life. So I'm a pediatric orthopedic surgeon. I'm used to doing tendon lengthenings through the normal big incisions everywhere, and now I very rarely do. It's almost all the tiny incisions. They're so small that they don't need any stitches. And then there's the alcohol nerve block that goes with it, which is it's like a super Botox, does twice as much as Botox and lasts about 5 times longer. And that's part of the techniques also. So with those, it's been very gratifying, the results that we've had. Oh, somebody's brain. Whoops. All right, so let's get started then. So I said that pretty fast, probably SPML, selective percutaneous myofascial lengthening. Percutaneous just means a tiny poke through the skin. Selective means you're going to select the place where you want to do that. The myofascia, there's tendons that connect to muscles. The tendon thins out and spreads over the muscle. That's called the myofascia. That's a really good place to do lengthenings because it's not so major as lengthening the major tendon. And lengthening means lengthening. So, so in medicine and in surgery, there's really nothing that's new. If you go back into the German literature far enough, you'll find it. So here's this guy Strohmeyer, and in 1831, he started doing these releases of tendons with the tiny little knives that they had back then that looked like little miniature swords. And so there he is. And then there was actually a Dr. Little. Cerebral palsy used to be called Little's disease, named after this doctor that actually had a foot that was turned in. So just looking at another condition, club feet. A child's completely normal, but the feet are really turned in. And back in the 1800s, it was all the tiny incisions. And then back into the 1970s, it was like, well, we can do big incisions and do more, because the frustrating thing is, even though the small incisions were effective, it would tend to turn back in again. So back in the 1970s, extensive surgery, but still a certain percentage didn't do that well. And then eventually somebody said, you know, the surgery is not really having, bigger surgery is not really having such a good result. Let's go back to the small incisions. And now it's come full circle, and now the standard way to treat clubfoot is with a lot of casting, bracing, and some tiny incisions. So I'm going to talk about cerebral palsy just because I have a big experience with cerebral palsy, but the techniques that I'm using to treat this kind of deformity in cerebral palsy I've also used to treat kids with brain injury. And you just have to look at each child and see what you think would be appropriate, what you think the results would be, and make a decision as to whether you think that would be a wise thing to try. So here we have, you can see, like, I would call it equinus. That's named after a horse. Horses walk on their toes, pointing down like a ballet dancer. The knees are bent. And the the knees are squeezed tight together. This happens to be a preemie, which is not exactly a brain injury because it has to do with the immature brain, but certainly with brain injury, there's a lot of different parts of the brain that can be involved. The brain's not too amenable to treatment, so we're left with trying wheelchairs, walkers, orthotics, and then maybe orthopedic surgery. Maybe you go see Dr. Prufrock if you saw his presentation and get something that he can do. So this is something an orthopedic surgeon would think about. So it's tight here and it's tight here. So which one should we treat first? And back in the years ago, it would be like, well, that would be a pretty big surgery to treat both of those, or it might be a pretty big surgery to treat both of those. But the problem is, the answer is you really should treat both areas at the same time. And if you're using the small incisions, it's not such a big thing. And it can easily be done all at one time. But if you would treat just this area, but the knees are still bent, then these ankles would come to straight 90, but even past. Or if you would start with the knees and get the knees straightened out, but the ankles are still pointing down, like a ballet dancer, that would tend, all that weight bearing on the forefoot would tend to push the knees back, and then the knees could go straight and then too far back. So you just need to be thinking to balance what's going on at the knee and what's going on at the ankle. And so, and this just explains that. So when the therapist told me I needed to start doing this procedure, I found out eventually that there was this Dr. Nuzzo in New Jersey, and he had started doing this by himself about 20 years before. So eventually I found his email address, sent him an email saying, I'm interested in doing this. And he said, yeah, you can do this. You can do a lot of parts of the body. It works really well. It works really well. And yeah, she's excited about the idea. And I said, okay, well, exactly where would you make the incision? How would you do the, and then he said, well, you really need to come and spend 2 days with me. And so I'm in Texas, he's in New Jersey. I had vaguely heard of him before. So then I said, well, so is there somebody else that spent 2 days with you that I could talk to? And he sent me this email address of Dr. Price in New York City. And so I contacted Dr. Price, and Dr. Price did his, did a fellowship in cerebral palsy surgery with Dr. Gage, who at the time was really the United States leader in cerebral palsy surgery. And Dr. Price said, yes, I spent 2 days with Dr. Nuzzo. He knows more about cerebral palsy than anybody, and it completely changed my practice. So I'm like, okay, I'm going. So that was 15 years ago, and Dr. Nuzzo and I visit him, he visits me. I say, okay, so this is a very difficult case. What would you do with this? And we can kind of go back and forth. So it's great to be my age and have an older mentor. So I'm going to start by showing a video. So you can see he's holding onto the wall because he's not too confident. You can see he'll put his feet down Um, but then they shake, the knees are bent. So what's happening? So for instance, he would put that foot down, it would shake, and then the heel would come down. So if you talk about a joint being tight, there's two ways it can be tight. One way it can be tight because you have too much tone in your muscle or spasticity. The other way it can be tight is the whole thing is just tight, it will only go so far, and maybe that's a tight tendon or maybe it's tightness in the joint. So if you're going to treat it, then it's good to know which is which because the treatment might be a little different for each situation. So this is the dynamic. It can, so you could really be bouncing this way quite a bit, but if you press very slowly, it could come completely straight. And that's typical when you're young. As you get to be old, you've had this for a long time, but then most of us, every time we walk or move, we're going to be giving it a full stretch. But as you get older, then it can get to be fixed in that position just because it doesn't get those full stretches with your daily life. So that is the fixed contracture. So motor control also. So there's this extra muscle overactivity, and can that limit your function? So what do the coaches say? Pitching, you need to relax. You don't want any tension binding yourself up. You only need to use those muscles that you need and not tense other muscles. The same way with golf, if you want a smooth swing. If you're playing a musical instrument, again, you're focusing on using the muscles you need. You're trying to get rid of excess tone, and also with yoga. So an important thing would be to try to find out, is it areas with excess tone, or is it areas where there is a fixed tightness that's limiting the motion. So now we're going to see the same child again. Also look at the knees and see how the knees are bent. And you can see the tight hamstrings. Look at the ankle, how he puts the ankle down, and you see it's shaking. But then he does get the foot down. And then he stands up and looks at his mom and says, "Really, why did I have to do that?" So he actually had surgery in the calf and the hamstrings, in the hip adductors, and we'll go all through all of these, and this obturator nerve block, and I'm going to show you a video. So this was an outpatient surgery under general anesthetic, the tiny incisions that don't need any stitches, and mostly focused on lengthening the myofascia. Welcome. So here he is after surgery. So you can see by, certainly he can get his knees straighter, he can get his ankles straighter, but also you get the sense that he is not like struggling against a resistance. He has the freedom to move. The other thing is he wants to move now, whereas before it was like, do I really have to?
Can I ask, was that also with like rehab after, or?
Not necessarily at his age. When you get over the age of 10 or 12, and in rehab would definitely be necessary, and if it's adults, to do this, I would want an adult that's already going to the gym and working out. But up to age about 8, they're so active and they want to move so much that now when I did the surgery before I learned this technique and I was putting the big incisions everywhere, then you really do need the therapy because there's more stiffness, there's more scarring, and you know, if you have the surgery and you don't move, you just sit in a chair and you're just going to get tight. Mm-hmm. Mm-hmm.
Is this surgery close to like HSN surgery?
Is it what?
Close to like, because I seen the surgery SPML.
Mm-hmm.
Is that close to like HSN surgery? Because I know that helps with contractions in the arm.
What is HS?
It's like a tendon release surgery in the arms, like in your biceps. When kids are like contracted and everything.
Maybe I'm not familiar with
Okay.
what HS is.
Okay.
Mm-hmm.
Because my daughter's about to get that type of surgery.
Okay.
Getting HSN surgery because her arms are like contracted like this,
Mm-hmm.
but it can go down,
Mm-hmm.
and she can move them up, and she tries to grab for things, but she's just stuck.
Mm-hmm.
So I don't know if I want to give her the surgery, but I want to give her the surgery because I want her to be able to utilize her arms again. 'Cause she's
Talk to me afterwards,
okay.
and we'll see. Okay. Yeah.
I kind of missed the first bit of the
Mhm.
class, but I don't know if you went over this, but like, how do you know when it's like that time to do it? Like, my son does have some, not like, he's not completely, stuck. We can get like that movement in,
Mm-hmm.
but he doesn't like stand, as much as like, we should, but, and he doesn't walk. So I'm wondering, like, do we wait? Might be a stupid question, but like, do we wait until he's like contracted and try to see if we can like not go that route, or if it's like in the middle and we know that it's really tight? When do you make that decision to have the surgery?
Well, what I would do is I would look at how he is now and talk to you about how he's doing, and then think about how he would do if he had the procedure, and what kind of difference could we expect, and then see whether you think that would be enough of a difference to try it. And if it seemed like, well, that might not be much of a difference, maybe just hold off. Or if you think, well, yeah, that would be a difference now, we should try it.
Yeah, I appreciate the honesty, because that's what I'm looking for, not just someone that's going to say, yeah, we should do it. Like, I don't want to put my son through that if we're not ready, if he's not ready for that, or it wouldn't benefit him. So.
Exactly.
And then also, like, you talked about myofascial release.
Mm-hmm.
So what about, like, should we, prior to the surgery, or like if we did do it, like, be working on the fascia system itself, like in the areas that we're doing? Because like we can do certain types of myofascial release is at home, correct? Or do you think that that's a different thing?
Well, there is myofascial release, which is like a deep massage.
It's not, well, I heard people say it's deep massage, but like the John F. Barn method is different. He actually does gentle releases, and he waits until it's like, I don't know at all myself, but he waits until it's like ready to release, and it's like actually a really slow, gentle approach versus what a lot of people think is deep pressure. Because we've been to two different therapists that have done it two different ways. Landon's responded better the other way, but I'm just wondering, because we're
I
kind
don't know.
of wondering
I don't know about that.
Okay.
It's mainly the myofascia refers to you have a tendon connects to a muscle, but then the tendon gets thin to a very thin layer of tendon. That's called a myofascia. So they're working on that area, and I'm working on that area, but what we do is completely different, I think.
Okay.
But certainly, if you could get good results with that and not have surgery, that would be good.
Seen really good just doing the John F. Barnes, I think it's called John F. Barnes method, but I just don't know if it's enough, I guess.
Yeah.
That's why I was curious to be here. Thank you.
Yeah, and then at the end, if you want, I've got these backpacks, but inside there's But inside there's some papers, which is I can do an evaluation for you if you fill out that questionnaire. Send me an X-ray and some videos. I'll go through it all, and then I'll call you up on the phone and we'll have an in-depth conversation about what realistically you might expect. Or
Because honestly, going in here really intimidated me because it's not a class I ever wanted to be in. But I was like, okay, he's here. It's literally what's been on my mind for the last probably few months. So I'm glad to be able to learn more.
Yeah.
That would be good. Thank you.
Yeah.
Does it help with foot drop also?
The question is, does it help with foot drop? Well, there's two parts of foot drop. One is that you have so much weakness that you can't pull your foot up. But the other is sometimes there's tightness pushing the foot down.
I think my daughter is the tightness.
Yeah,
Because she tends to
Yeah.
extend like this,
right.
so she has foot drop in the back. She did serial casting and it's back to
Yeah, yeah. So, so a lot of times, so like she can't pick her foot all the way up, but she can move it up a little bit. Weakly is common. So then if you can loosen this up, then she'll have the ability to hold it completely up.
would it need casting after that?
Yes, so you would, so there would be the release, the tiny, tiny incisions in the back. She would be in a cast, holding it in the straight position for 4 weeks. Is she in an is she in an AFO?
She has them, but she hates it.
Yeah. So if she hates it, I would just stop using it. But then because usually if this is tight, you're trying to get the AFO on and it doesn't fit, and you have to strap it down so hard that it's completely uncomfortable. So that's a good sign that probably that would be indicated to have the procedure, just so she could be comfortable wearing the AFO.
What if her foot is turning in a little bit?
Sideways,
Yeah, like coming in a little bit.
like walking on the edge of the foot, or like,
Yeah, inwards. She has like a little ball, like from her foot turning in like that a little bit. So, but it's not dropped. Her foot is not dropped. So, but that's,
I would,
it's hard to put her braces on.
oh, okay. Well, if it's hard to put the braces on, she'd probably be a candidate.
Okay.
But yeah, you would need to grab one of these and send me the information, and we'll go through it all.
Do you only operate in Texas?
Yes, I do most of my surgeries in League City, which is a suburb on the south side of Houston.
So the fascia, how does that relate to muscle spasticity, or how do I tell the difference whether it's tendons or if it's just the tightness from spasticity?
Well, they usually go together. So, so with the muscle spasticity, then gradually you get tight.
Okay.
Yeah.
So she, we do Botox,
Mhm.
and that's helping
Mhm.
a lot, but she still has a little tightness, and her doctor is wanting to do a baclofen pump, but she's taken baclofen just like the pill before, and it does nothing for her spasticity.
Yeah.
It just makes her sleep
Yeah.
all the time.
Yeah.
And so they said that our other option is the dorsal.
Selective dorsal rhizotomy.
Yes.
Right.
And so I don't know if this would be another option that
Yeah.
could help with the tightness instead of.
Yeah, that's a good question. So, well, those surgeries can help some people, but the first thing she mentioned was the baclofen pump, which is a marvelous device, but it is about the size of a tuna fish can and has to be placed under the skin of your belly. Then there's a little tube that runs and puts the medicine into the cerebral spinal fluid in the spine. Um,
And she's just a completely different kid on baclofen. It's when she got off of it and we did Botox instead, she's so much more like,
oh, the baclofen sedated her? Or,
so much on
Yeah.
such a small dose too.
Yeah.
Like the lowest dose,
Right.
and she was sleeping like 20 hours a day.
Right.
It's crazy.
and the other one she mentioned, the selective dorsal rhizotomy, is it's a surgery on the back where you cut some of the sensory nerves to cut down on the reflex arcs to cut down on the spasticity, but you're permanently cutting nerves. It can be very helpful, but for both of those cases, I would say if you're a candidate for SPML, try the SPML. It's just, it is an outpatient surgery, but you'd be in the hospital just 5 hours. It's very minimally invasive, extremely low complication profile. So, yeah, good question. Mm-hmm.
Would it affect, so his orthopedist was recommending hamstring lengthening. If we did this,
Mhm.
could in the future, and it doesn't work, could we try hamstring lengthening, or does it interfere with future choices?
Yeah, you can do so I saw frequently I'll see somebody that had hamstring lengthenings 5 years previously, and they're adolescent, they're growing really fast, hamstrings got tight again, and then I can do the hamstring lengthening again. Mm-hmm.
That
Yeah.
brings me to a question. My daughter's 13, just went through a growth spurt, and we're dealing with a foot drop and an outturning of the foot
Mm-hmm.
because of they're saying it's the heel cord.
Mm-hmm.
And so they're recommending serial casting starting in January,
Mm.
which is why I came to see you.
Mm.
If we do an SPML procedure, can
Mhm.
it be redone then? If another growth spurt happens
Mhm.
in the future, you can redo it.
Mm-hmm.
Okay.
Yeah, usually with the ankle, if you can stay in AFOs for 8 hours a day, there's only about a 5% reoperation rate. Mm-hmm.
Yeah, she'll tolerate them at school. They can get her to wear her AFO with some
Well, but
cords in place. But
yeah, and just like I said before, so if you're tight and you're trying to squeeze yourself into AFOs, and it's not going to be comfortable, then she's not going to want to wear it. But then if you can be released, so now you can very gently and easily go into that position. The AFO is not forcing her anywhere; it's just maintaining that position.
would that
Then
be in lieu of a cast or after the cast?
it will be a cast for 4 weeks,
And
and then the AFO.
yeah, and the reason why she's not wearing the AFO now, there's a turning out of her foot, so there's a lot
Right.
of skin breakdown because she has an arch collapse.
Exactly.
Heel.
Yes.
Yeah.
Yeah, that happens when it's tight here, and you push up there, and then the arch.
Right, because you
Collapses.
used to get that clonus, and now we're getting,
Right.
I think she's in contracture now.
Right.
Because she's 13.
Yeah.
So I can fill out the paperwork also?
Absolutely.
Okay, all right. We
Yeah.
do live in Philadelphia, so we're much closer to your friend in Jersey than, but I would like to start the conversation.
I don't want to brag, but I've had several people come from Australia, South Africa, India, England, and I guess probably half my people are from Texas, but it's all over Texas. And the other half, other than the international, are California, Florida, all over. Yeah. Mm-hmm. Yeah.
Do you think her feet could be released, or is it too contracted?
Oh, yeah.
They're very tight.
Yeah.
I don't know what they
Come
call
up.
that, but it's
Her
very.
her feet are turned in, almost
The
sideways.
reason we haven't done casting is because we're really nervous about it, because this bone almost sticks out because
Yeah.
the skin's stretched so far.
Yeah.
So how would we know if we put
Come
the
and-
cast, if there was
Come
skin
and
breakdown?
come and see me at the end,
Okay,
and let me feel with my hands and
okay,
give you an idea.
okay.
Mm-hmm. Mm-hmm. Yeah.
With the alcohol block, can you still use Botox as
Yes.
in conjunction with that?
Yes.
Do you notice after the alcohol block that there is an ability to wean off of medications like baclofen and other anti-spasticity meds?
Yeah, that's a big hope of everybody. Sometimes. Yeah. Mm-hmm. All right. How are we doing for time? Is it 2:20? 2:19. Okay. So we've got some time. Yeah.
You had mentioned it's an outpatient procedure.
Mhm.
Is it still full sedation?
It's a general anesthesia, but I have a more of a like a kinder, gentler type of anesthesia that we came up with just for the kids having this procedure.
Oh, okay.
Mm-hmm. Yeah.
And then afterwards, are they still wearing the same type of AFOs that they did before, or is it a different type of AFO that you would need?
Usually it's a standard type of AFO, but if they need a special type,
Well, I
but
heard somebody else had told me they had went through SPML. I don't know which doctor.
yeah.
And the AFOs that followed afterwards were like opposite. Instead of going how they needed to, it was
Oh.
pushing into their old pattern.
Oh,
And I
Oh.
didn't know if you knew anything about that.
well, yeah. So they need to be in the right kind of AFOs, and we would discuss that and do what we needed to do to get the right kind of AFOs.
Okay.
Is the
That's a
hope
big
that
part
you
of
get
it.
them out of an AFO eventually? And how long are they in an AFO after the procedure?
The
You worked yourself out of one,
Yeah.
now we're back in one after the growth spurt.
yeah. Well, it's delightful to get people out of AFOs. If is she an ambulator? And does she use like a walker or walks independently?
No, she runs hips, jumps, skips,
Okay.
hops. She's worked her way out of PT.
Yeah.
But with the outturning of the foot and the arch collapse,
Yeah.
it's getting progressively worse because of the
Yeah.
cord.
Yeah.
So she worked her way back into an AFO because
Yeah.
of the positioning of the foot.
Right.
And they want to lengthen the heel, so they want it at a 90-degree angle for a certain amount of time a day.
Yeah.
We're now doing stretching and, like I said, up for serial casting. But
Mm-hmm.
she was out of an AFO from ages 6 up until 12.
Mm-hmm.
And I'm just hoping to get her back to where we were
Mm-hmm.
before.
Mm-hmm.
The AFO prevents some movement. It's
Right.
restrictive for her.
Well, in terms of the tightness in the calf, someone like her would be allowed to walk without an AFO. But if she has the foot that turns out with a low arch, that's a separate problem. And to treat that, you have two options. One is you can try to hold it in AFO, but once you get big and old, it causes too much pressure on the arch of the foot and causes pain and sores. So correcting that collapsed foot with an AFO is effective until maybe age 10 or so. And then when you get to be a big person, that's not really realistic. So then you have a choice of either accepting that you have a low arch and your feet are turning out some, or else doing a surgery that works on the bones inside the foot to rebuild the arch.
So it's the heel cord and the arch rebuild then.
Yeah, and then she could get out and have both, right.
You do both those,
Mhm.
the other one is
I do.
minimally invasive, the other one.
But I do both, but the rebuilding of the arch is not minimally invasive, yeah. Mm-hmm. And she would, it's both feet, right?
Just one foot.
Oh, just one
Because
foot.
I'm right-handed cleaved.
Okay, so that makes it easier, but, so non-weight bearing on that one after rebuilding the arch for a month. And probably be in casts for 2 months or so. Mm-hmm. Mm-hmm. Yeah.
If because of the tone, the bone has started to grow differently and change the shape, does that make them ineligible for this procedure?
No, usually not.
Okay.
No. Well, yeah, how old are they?
Grayson's 9.
Okay, yeah. Sometimes with older kids, but usually it's not a problem.
Okay.
Mm-hmm.
So just case specific.
Mm-hmm. Mm-hmm. Okay. Probably I timed out here. So I was talking about Dr. Nuzzo. Yeah. He just turned 80. He's still doing surgery, but now he's working with some other doctors to be there. But,
Is he training more dogs?
well, yeah, and I'm looking for people to train because I'm not quite his age, but I'm not super young anymore. So what I need is pediatric orthopedic surgeons that want to learn it, and they need to get in touch with me because I'm really trying to train people right now.
What is the difference? Because I know, like our orthopedic surgeon, I mentioned the SPML.
Mm-hmm.
It's like, oh, well, we do that here, but is that different? Is that tendon?
Well, he doesn't really know what I do.
Right.
So, but what he's probably saying is, I do percutaneous surgery at maybe 2 or 3 parts of the body for very special indications. But he probably doesn't do nerve blocks. He probably doesn't do the minimally invasive of the calf.
Because it's
Yeah.
just like a different.
It's a whole world, yeah,
methodology.
of itself.
Okay.
Right. And so, yeah, it doesn't sound like you'd be interested in learning. But next time you see him, just tell him, Doctor, you need to learn this. And maybe if you tell him 5 times, maybe he'll like something. Yeah. All right. So Dr. Nuzzo had done 278 cases and followed up how they did later on. He had recurrence in 7%, no cases of infection or over-lengthening or significant hematoma. And my results have been similar to that. So this is what we've been talking about, so it's tight here, and the tiny incisions would be here. So this is the Achilles tendon, and then the fascia is up above here to the muscle, and so here you can see it again. So here's the Achilles tendon coming to about here, and then you can see this looks like tendon, but it's wrapping around from side to side, and then this is just the muscle. So this is thin. It's almost like paper thin, but it's a strong tendon. So releases here, that stretches out. There's a gap there which fills in and heals. The muscle underneath it stretches real easily. So it becomes a lengthening. So short leg cast for 4 weeks, and then they're usually into a solid ankle AFO and then later a hinged AFO. So now here's you can see the tight hamstrings. And then this is the foot, I think, like you were talking about here with where it collapses on the inside.
And the AFO now is just causing such breakdown because of the positioning of the foot. It's really painful.
I can't advise because she's not my patient because I've never seen her. But you might think about just not wearing the AFO.
Okay, if she has a lightweight shoe on, she can manage just fine.
Yeah, just find some shoe that's comfortable for her.
All right.
Because the problem is the orthotists, bless their hearts, and I know a lot of really great orthotists, but they look at this foot and they say, that foot's not in alignment. Mm-hmm. And as an orthotist, I can align that foot. Right. But to align that foot, they have to push really hard there, which like I was saying, that works when you're young, but when you're old and big, it doesn't it
And you wonder
can't
why
work.
he's wearing it, it's causing so many blisters.
Yeah,
and-
yeah. Mhm.
Yes, it is.
So the hamstring, there's 4 different tendons on the hamstrings, and commonly I would lengthen these 3. If it's an older kid, really severe, I would release this one. If it's someone just with a really mild contracture, and I'm worried about they may have too much release and go into back knee, I would just, but I still want to do a little bit, I would just do this one only. And so here you can see, if I did that one only, it's just that one, and how they come back along there. And then this is a cross section. So if I did one only, it would be this one, and then if I do 3, it's this one, and this one. So you can see the black part is the part that I would release. And so I would just release along the edge right there, and just this little bit there. This part here is all the muscle, and then that doesn't get released at all. And that just easily, the muscle easily stretches out. And then where these tight areas have been released, it makes a gap, but then that fills in. Just to remember that the hamstrings are behind the knee, and so they're associated with the knee bending, but also they're attached up to the hip. So if it's tight, you might not be able to swing your hip forward as much because it would be tight there. All right, now we're moving on to the hip. So this boy, you can see he's squeezing his knees together. He's leaning over this way. When you're squeezing your knees together, you're tightening up these muscles that are inside the hip, and so these muscles they run like this. So when they tighten up, they do pull the leg in. But you can see that really what it mostly does is pull this way because of the angle of it. So it's pulling the leg in, but it's also pulling the leg up this way, which is 1 and 2. It can start pushing the ball out of the socket. It's very strong. So, but these some of these kids will tense so strong, and they'll do it like 1,000 times a day, and they'll do it year after year. So that's what slowly it can mold. And so here you can see the difference? This would be a normal hip here, and this would, can you see how the ball is working its way out of the socket there? And so, so in that case, this is a really, and it's not that bad yet, so it would really be good to release this adductor here, and there's an obturator alcohol nerve block for that also to take the pressure off. It's not enough, usually it's not enough to get the hip to go back into place unless you're 3 years old. It could, but certainly it's taking that bad force away. And then this is somebody else, but then this is eventually what it can look like when the, when the hip goes out of the socket. And then, can you see, this is the normal looking one here, and here is the one that is just starting to work its way out. And so this is pretty serious. So if anybody, if anybody thinking about coming to see me, I'll have you send in a questionnaire and a pelvis x-ray, and then I actually take a ruler and I measure how far out this is, and I measure what the angle of this bone is here. So, and that gives me really an indication of what our history has been with this kind of tightness. And so, so certainly if the adductor is tight and it's causing a problem, if there's scissoring, this acetabular dysplasia, that's if as this starts working out this way, this roof here should really come across and then come down around. But if it's just going up like this, if you're having that, that's another indication. And if you're having hip subluxation. And so the area where the release would be, this is looking down from the top, the release would be where those muscles come in to the pelvis right there. And obturator nerve block is done along with it. It's a excellent thing with extremely safe. A small amount of this 50% ethanol, it decreases the spasticity, and because so if you have a child where the legs are squeezing in like that, and that's because the muscles are tensing, but the muscles are tensing because there's a nerve that comes down into that muscle, and when that nerve fires, it says, pull, 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 pull. So what the alcohol nerve block does is it puts the alcohol medicine around that nerve, and the nerve has a fatty coating, the myelin sheath, and it dissolves a patch of that myelin. So it slows the nerve down to more of a normal nerve. It's like people are speeding through your neighborhood and they put in speed bumps, and now people go more slowly. So it works really well in conjunction with that adductor release. And so this is how it's done. This is the needle, and this is the nerve coming out of the pelvis and going down to that adductor muscle.
How long do those nerve blocks work?
Good question. I would say 6 to 18 months. Mm-hmm. Longer than Botox.
Come back and redo it?
You can.
Or does it just
You can.
train the muscle to not?
Somewhat, yes. And since I've also done the release of that tight tendon at the same time, and now they are, like you say, they are using it more and learning to use it more, that it's, I have a few people where, and I want people to wait a year before they come back to see me for more. I have a few people that are so incredibly tight that they do, but with a normal kind of tightness and spasticity, yeah, at least for several years or maybe permanently. So in summary, the SPML surgery, there's less contracture, better range of motion. There's less muscle tendon unit tension, results in less triggering of spasticity, and then less spasticity results in better motor control. And that's the end. Questions? Yeah.
How early have you done surgeries? Like, how many kids have you?
2 years.
2 years.
Mm-hmm.
2 years, but they are already super sensitive.
Yeah, for brain injury, for brain conditions. Actually, for children who have club feet, they actually have it done at 2 or 3 months, but it's just limited to that side heel cord area. But for the kids with brain involvement, most kids don't need it at 2, but there are, usually it's 3 or 4.
And then what about a kid who's got, I work with special needs kids, so I
Oh,
work
okay.
with all my clients.
Yeah.
What about a child who's had cerebral palsy and it's really severe, and now they're 14, 15 years old.
Mm-hmm.
And so I think it would be, not the spasticity, but actually the tendon is now shortened or stuck. I mean, and it's all over the whole body, so.
So she has a,
Would you
yeah.
try like doing, hips, calves, ankles all at the same time just to see what happened, or how would you kind of approach
Maybe.
it? Maybe.
Yeah.
Just depends on the case.
Right. Yeah, so she says, what about a 14 or 15-year-old that's now tight? Several different places.
Yeah, head to toe, really.
And sometimes, I have some kids like that I'm not doing anything with. But then if they are like difficult for perineal care, or if they're having pain, or if they can't get up and stand her anymore, or so you have to kind of make a determination of what the benefits would be, and would that be enough to warrant going through a procedure like this. But no,
You've done multiple.
I've definitely done a lot of severe kids. Oh yeah. 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 Yeah, I've been doing a lot of pec releases for the kids that are forward like this, and the elbows are up like this, and probably shouldn't say this. So there are kids that extend and or arch.
Yeah, so you've done
And I've done some of those kids. It seems like it lasts 8 to 9 months for those kids. So those kids, for most kids that are arching, it's not that much of a problem. But for some kids, they can't even sit in their car seat because they're out like that, and that can make a big difference. Yeah.
Thank you.
Mm-hmm. And that when I do that, that's all the alcohol blocks on the muscles of the spine back there. Mm-hmm. Mm-hmm. Yeah.
So I have two. One is, you talked about casting for the lower leg. If you're doing surgery up here, even in the upper leg, are they getting casted?
Good question. The only casts I use are at the ankle area, so it's like from the calf to the toes. I'm not casting the knees. For the knees, for the hamstrings, they have a knee immobilizer, like a foam with the Velcro straps that they wear for the first 24 hours, and then just at night for 2 months. Just as a reminder not to sleep in the fetal position.
Do that in the arms as well? If there was a release in the arms, they have an immobilizer for the elbow?
Yes. Mm-hmm.
And then
And for the pecs, you're just doing exercises if it's the pecs.
I was also wondering what kind of risks come with this? Like even with the alcohol block, you were talking about the myelin sheath. So what problems could it cause, or what kind of risks would we see with either of the procedures?
Well, most of the nerves in the body do not have a myelin sheath. Like all the nerves in your abdomen, like go to your stomach. See, your arms and legs, they have to operate really fast. So if you feel something, you need to know right away, or if you have to jump out to catch yourself because you're falling. So that's the really fast nerves. But with some of these kids, then it's causing too much of that. But so what happens is that the myelin sheath regrows. That's why it lasts 6 to 18 months, because that's how long it takes it to regrow.